Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. Today's episode is from our program on managing COVID-19 in individuals with metabolic syndrome and obesity. I'm happy to introduce our expert faculty, Dr. Donna Ryan at Pennington Biomedical Research Center in New Orleans, and Dr. Renslow Sherer at the University of Chicago. They'll discuss how obesity affects the risk for COVID-19 and vice versa. They also examine COVID-19 vaccines and antiviral therapy in the context of obesity, and to strategies to prevent or treat long COVID. For more information on Dr. Ryan and Dr. Sherer, along with a link to the complete program, including another podcast, downloadable slide set, and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
I'm going to be talking to you about the relationship between obesity and COVID-19, two converging pandemics. It does not come as a surprise to anybody that we've got two epidemics on our hands. One epidemic of COVID-19 and another of obesity. Currently, in our latest NHANES survey, and that was before the pandemic, these data are actually from 2018, the prevalence of obesity as judged by a BMI of 30 or higher, and that's your ICD-10 code for obesity. That prevalence is 42% of U.S. adults. We all know that COVID-19 is a similar epidemic, and there have been over 1 million deaths in the United States. But both of these, both obesity and COVID-19, they're pandemics. They are global issues, global problems around the world. And the problem is the collision of these two pandemics. So I'm showing you here evidence of how obesity is associated with adverse outcomes from COVID-19. We know that individuals who have obesity are at higher risk for hospitalization, for requiring an intensive care unit visit, for requiring mechanical ventilation, and for death from COVID-19. And according to the CDC, adults with obesity are 3 times more likely to require hospitalization than those whose body weight is normal. From the UK National Health Service, the lower the BMI, the lower the need for ICU admission. And the higher the BMI, the more likely the need for ICU admission. And actually, the odds ratio crosses 1 at a BMI of 24. So there's a relationship where individuals who are underweight, who have lower BMIs, are at increased risk for mortality with obesity. And this is true with COVID-19. And that's really because individuals who are underweight frequently have other associated illnesses. So BMI of 40, and 40 is about 100 pounds overweight. We have, according to the last NHANES survey, over 9% of the U.S. population has a BMI of 40 or above. That is an independent criteria for bariatric surgery. Of course, the impact of obesity on what happened with COVID-19 in the United States has really been profound. So how actually does obesity drive disease? It's associated with lots of comorbidities, not just bad outcomes from COVID-19. So there are 2 primary mechanisms. First of all, just the burden of excess fat itself can cause disease. So excess fat around the neck, for example, can lead to obstructive sleep apnea. The burden of that excess fat can promote knee arthritis. Increased intra-abdominal pressure from visceral adiposity can promote GERD. And that impaired diaphragmatic motion and the external reduced capacity can impair lung function. That impaired lung function is one of the reasons that obesity is associated with bad outcomes from COVID-19. But look, that's not all. Obesity is a chronic pro-inflammatory, prothrombotic state. It's also associated with abnormalities of immune function. And individuals who have excess abnormal body fat, and that's the real definition of obesity, abnormal body fat produces abnormal cytokines and lipokines, and that promotes cardiometabolic risk. So there are 2 main mechanisms, the burden of fat and then the lipotoxic effects of that excess abnormal body fat itself. In COVID-19, what's going on? We have the burden of fat that's promoting a reduction in pulmonary capacity, abnormal pulmonary function. But we also have a prothrombotic, pro-inflammatory state, and that promotes some of the complications that occur with COVID-19. In addition, individuals with obesity have an increased risk for all of the cardiometabolic diseases: diabetes, hypertension, dyslipidemia, cardiovascular disease, 13 kinds of cancer. And so we know that individuals who have more than one chronic disease have an increased risk for adverse outcomes of COVID-19. So it's directly and indirectly, obesity is really driving adverse outcomes of COVID-19. Now, I think it's worthwhile saying that obesity and COVID-19 have a biologically synergistic relationship. So because obesity is promoting this pro-inflammatory, prothrombotic endotheliitis and immune dysfunction, it tends to make COVID-19 worse. But look, individuals who have COVID-19 are in a stressful situation. They also have individuals during this pandemic have had weight gain due to lack of exercise, due to lack of access to healthy foods. And so COVID-19 can make obesity worse. There's also evidence that COVID-19 can affect the pancreas, damage it, promote insulin resistance, type 2 diabetes, and worsen obesity. So there's this biologic synergy going on. But look, there's a syndemic aspect to this too. So what a syndemic is, that's an epidemic where there are social and societal drivers for both obesity and COVID-19. There are social determinants of health, aspects of the social environment and physical environment and societal environment that promote risk for obesity and also promote risk for COVID-19. Both of these are synergistic and syndemic. Okay, now I'm going to talk a bit about long COVID. Individuals with obesity are also at increased risk for long COVID. This is also called PASC, post-acute sequelae of SARS coronavirus 2. And the reason for that is individuals with obesity can have systemic viral persistence. Because they have immune and metabolic dysfunction, they may persist in carrying the virus. Also, adipose tissue has ACE2 receptors on it. And we know those spike proteins on the SARS coronavirus, that's how they get into cells. So we now know that adipose tissue can be a reservoir for SARS coronavirus. And that may be one of the reasons that individuals with obesity are more prone to long COVID pathologies. And then also there's that chronic inflammation that occurs with obesity. And that may be priming individuals for the chronic inflammation response to COVID-19. What's going on there is that individuals with obesity have a higher risk of developing this long COVID. And the higher the BMI, the greater the risk. In the United States, remember, we have a bell-shaped distribution of BMI where we have a lot of people who have really severe obesity, and that is a big risk factor for long COVID. We think that overall, about 10% of cases of COVID-19 result in long COVID. Of course, the more severe disease, the greater the likelihood. But because we have so many more cases that are not requiring hospitalization nowadays, we actually see more cases of long COVID for individuals who were not hospitalized. But one of the big protectors against long COVID is vaccination. It's not perfect. About 10 to 12% of people who have been vaccinated who do develop COVID-19 will develop long COVID. So what's going on there in that pathology is that there are multiple organs that can be affected and probably multiple pathologic mechanisms. It may be viral persistence. It may be mostly inflammatory components, but any organ system, heart, lungs, immune system, pancreas, gastrointestinal tract, the brain, the kidneys, blood vessels, etc. All of these can be affected by long COVID, and individuals with obesity are at higher risk for long COVID complications. I'm going to turn this over now to Renslow to take it away.
Thanks so much, Donna, and it's a pleasure to be with you all. I'm going to talk about COVID-19 vaccines and antiviral therapy in the context of obesity and the metabolic syndrome. So let's dig into this a little bit. Now, I'll start just by following up on Donna's excellent presentation, thinking about the impact of obesity across all the different COVID-19 clinical stages. There's a greater likelihood for early infection and a higher virus replication in folks with obesity compared to normal weight, and a greater likelihood for more severe presentation of a respiratory phase with hypoxia and dyspnea, pulmonary involvement because of the restrictive lung disease that can be associated with obesity. And that also carries over then into a greater likelihood in hyperinflation, again, for the reasons that obesity itself is a pro-inflammatory syndrome. There's a greater likelihood of transfer to intensive care, of the incidence of ARDS and multi-organ failure in people with obesity. And I think that reminds us about some of the greater evolution of our understanding of the clinical manifestations of COVID, particularly for those in hospital or in the clinical presentation for severe COVID. We would think of that as folks with substantial hypoxia, so less than 94%, and a compromised FiO2 with a respiratory rate greater than 30, with a chest x-ray that shows more than half, more than 50% with lung infiltrates. The clinical implication of the designation of severe COVID is that these are folks at risk for a much more rapid continuing deterioration who absolutely should go to the ER, should be hospitalized, and should receive oxygen therapy. In the definition of critical COVID-19, you're much more likely to have ARDS that qualifies, septic shock, cardiac shock. I would say any substantial prolonged hypotension in association with the so-called viral shock of COVID-19 qualifies. And then evidence of this sustained chronic inflammatory response with high CRPs, with high ferritins, with high IL-6, if that can be measured, with an increase in D-dimer and other associated laboratory values for thrombogenesis. And the clinical implications for that designation is that should be in intensive care. They should be considered as candidates for tocilizumab or other JAK inhibitors, treatment with immune modulators. Also understood to be at greater risk for other comorbid conditions and for the incidence of nosocomial infections, line infections, or ventilator-associated pneumonia. If we start with our therapeutic approach with prevention, the best way to manage this, which now, fortunately, most people, the vast majority in the United States, have had at least a single vaccination, if not a complete set. The best prevention is vaccination. And so the recommendations now, as you see here, are for completion of a primary series for everyone aged 6 months to 4 years. For those who are 5 years and older, that includes all primary series and the bivalent booster, which should be given 2 months after the second dose. The use of the bivalent booster is recommended for all those over age 5. Following up also on Donna's really important point on much of the long-standing morbidity that we're seeing now even for subclinical or mild presentations of COVID, it's very important to think about and to talk to our patients about the potential impact of COVID-19 vaccination on long COVID. And a couple studies have tried to look at this carefully, and it's quite a complicated epidemiologic and scientific issue. In this study from Notarte in The Lancet, which was a meta-analysis of 17 studies looking at the incidence of severe symptoms after an acute SARS-CoV-2 infection, this was like over 17 million individuals. They were able to establish that vaccination before SARS-CoV-2 infection was associated with a reduced risk of developing long COVID. And there was some evidence that 2 doses were better at this than 1 dose. And I think all of the available data suggests that a complete series is a far better protector against any infection, and then particularly against severe infection and hospitalization and against long COVID than is a single dose. There was another study also more recently in BMJ, also a systemic review looking at a total of 141,000 patients in 16 studies. following the incidence of long COVID, both before vaccination or after one or more dose. And again, because of the difficulty in these heterogeneous analyses, you have to take this with a grain of salt. But I would say it's important that the evidence that they found was that vaccination before SARS-CoV-2 infection trended towards a reduction in the development of long COVID. This has been true in other studies as well, that the use of vaccination in people who are actively having long COVID has been associated with a reduction in symptoms. And I think that'll be on a case-by-case basis. But I think it's important to know our best way to approach long COVID is to try to prevent or mitigate a long COVID infection. So let's turn to the management in the outpatient setting. This is mild to moderate COVID-19 in people with obesity or with metabolic syndrome. The very first important question, are there risk factors for severe disease? And I think this audience is very familiar with anyone with age over 65, or actually age over 50 with multiple comorbidities, and then obesity and significant cardiovascular illness, chronic lung disease, chronic kidney disease would fit into that group with risk factors. In the event that this is the case, that yes, there are risk factors present, then the next determination is there dyspnea or is there evidence of hypoxia if they happen to have a pulse oximeter at home? If the answer there is yes, so if you have significant dyspnea, that would be a reason to advise a patient to go to the emergency room for evaluation and be considered for either therapy as an outpatient or possibly hospitalization and then inpatient therapy. And there's a very important bullet there. It's actually a broader list for thinking of people who are at risk of COVID who you might refer to the emergency room. And that would include altered mental status or severe chest pain compatible with ischemic heart disease or an MI, or sustained prolonged high fever or severe abdominal pain or prolonged vomiting. I think you would send any patient to the emergency room, but it's important to remember the heterogeneous presentation of SARS-CoV-2. It isn't always exclusively associated with hypoxia or dyspnea. Nonetheless, if the answer there is no, there's not moderate or severe dyspnea, there's none of those other symptoms. And if that individual has had symptoms for less than 5 days, they do qualify for therapy. And I think because of the benefits of therapy, I still am in the business of strongly recommending to people, friends, family, to my own patient population with HIV, any others who are immune compromised, that they consider taking oral antiviral therapy or intravenous, as we'll see. And if the answer there is no, if it's within 5 to 7 days, they still might qualify for remdesivir. And I think an important point here is in any event, we shouldn't stop testing for COVID-19, particularly in those who have substantial risk factors or in my peers who are over age 65, because of the availability of this potentially life-saving therapy. So we still need to be SARS-CoV-2 testing in order to identify people with active disease. So the current NIH treatment guidelines prioritize therapy in the following way for, again, people with mild to moderate COVID-19 with a high risk of progression, and that would include people with obesity. First, nirmatrelvir plus ritonavir, that has the advantage of being an oral drug. It's dosed twice daily for 5 days. It's a weight-based, so those who weigh greater than 40 kilograms, there's a specific dose. And the very important consideration is the studies show benefit if it's given within the first 5 days of symptom onset. Importantly, there's drug interactions that are a consideration, but are rarely a deal breaker for the administration of this agent. There is a recommendation for renal dosing, halving the dose in those who have a glomerular filtration rate from 30 to 59. Also, a preferred alternative is IV remdesivir daily for 3 days, which requires an infusion center or a special section in the emergency room or clinic where that can be administered. So that can be logistically complicated, but that can be given within 7 days of symptom onset, according to the phase 3 clinical trials. And then the alternative, if neither of those two are available, is molnupiravir. That's an oral drug every 12 hours for 5 days in those who are aged 18 and over. The evidence is somewhat weaker than for the other two. The efficacy is substantially lower in clinical trials, and then it should not be used in pregnancy and only with caution in women of childbearing potential. So these are the 3 phase 3 trials that led to the emergency use authorization for these agents. In the EPIC-HR study, either after 3 days or after 5 days from symptom onset, the relative risk reduction in either hospitalization or death compared to placebo was 88 and 89%, with a highly significant p-value. In the registrational trials, the Pine Tree study, remdesivir, with a start date within 7 days of the onset of symptoms, the reduction with 3 days intravenous administration of remdesivir was 87%. And then in the move-out study with molnupiravir orally with start date within 5 days, the relative risk reduction was 30%. And so there you see the hierarchical listing from the NIH and the rationale for it, the lower performance with molnupiravir. I mentioned the drug interactions. This is a very handy website that many of you are familiar with or using for people with HIV or with other medications that have some complex drug interactions. This is specifically for COVID-19 interactions, in this case with either remdesivir or nirmatrelvir and ritonavir. You can see here there's a couple of medications, amiodarone or tacrolimus, that are contraindicated with co-administration. For the majority of drugs, in most categories, there's either a caution with simultaneous administration. There's some recommendation for holding some therapies, for example, some statins for the 5 days that the drug is given and another period thereafter. So I think this is quite manageable, should not be a reason to shy away from the use of the easier to administer oral nirmatrelvir plus ritonavir. I don't think any clinician should be intimidated by that list, and it requires checking with the individual medications that your patient is receiving. If we look at the schema for the benefit of early outpatient antiviral therapy and its timing, it really is critical that we get to patients within those first 5 days. This is the strongest rationale for continuing to do home or hospital-based or clinic-based testing for SARS-CoV-2 infection, just to identify, particularly in the elderly or people with other comorbidities and those who are immune compromised, when they might be a beneficiary of therapy. If you think of the clinical signs and symptoms during this time, it's with an influenza-like illness. And the treatment goals at that point are reducing onward transmission. It does have a benefit for transmission, but particularly reducing the incidence of hospitalization and overall morbidity and mortality. And clearly antivirals are indicated in that period of time. The jury is still out on this really important question. Can early antiviral use prevent or treat long COVID? And as I said earlier, I think our best steps with our patient population is to vaccinate in order to prevent all SARS-CoV-2 infection and at least prevent long COVID. And I think the evidence is really compelling. That is a benefit of vaccination. Because of the potential for antiviral therapy to decrease the viral reservoir in that initial critical early period, there's a good rationale for an impact on pathogenesis and a reduction in long COVID symptoms. And we will be getting more data, both from the PAX-LC, nirmatrelvir, ritonavir study that's enrolling people with long COVID, from the Solidarity study where they'll have 1-year follow-up data, and with molnupiravir in the Panoramic study with looking at data 3 and 6 months post-treatment. So we should have better information on this. But I think there was a useful recent study in JAMA that was out of the VA study looking at the impact of therapy on PASC symptoms. And this was in a large group of patients in the VA overall, 9,200 people who were treated with nirmatrelvir, ritonavir, compared to 47,000 who were not. Half of these patients were vaccinated and boosted, and then another quarter had 2 vaccines. So we have most of these patients receiving vaccines. The use of the nirmatrelvir, ritonavir therapy, almost all of those chronic symptoms, with the exception of liver disease, cough, and the incidence of diabetes, everything else, ischemic heart disease, dysrhythmia, pulmonary embolism, and DVT, acute kidney injury, neurocognitive impairment, dysautonomia, all were shown to be, in this observational study, reduced with the use of nirmatrelvir ritonavir. I think this is really compelling data that we should share with our colleagues and with our patients. Overall, PASC was reduced by 26%. The risk of post-acute death was reduced by 49%, and post-acute hospitalization by 30%. Within 60 days, there's more than 2 fewer PASC cases per 100 people treated, 0.2 fewer deaths per 100 people treated, and then 1 fewer hospitalization for every 100 people treated. In this observational setting, I think it's pretty compelling evidence that there is an effective therapy on long COVID. In terms of what are the most promising strategies, particularly for treatment of long COVID, I think I've already said vaccination's the key, and there's a lot of research in Recover and other studies looking at potential therapies for long COVID, like coenzyme Q, like probiotics, like the omega-3 fatty acids, with no conclusion. And I would say that this would be a really good time for your patients with long COVID to be enrolled in some prospective long COVID study that may or may not offer therapy, just so that we're trying to learn as best we can from the patient population that we're serving. So it seems like we're moving towards individualization in the management of patients with long COVID. I think it's clear that we're going to see long COVID in those patients who had more severe disease and hospitalization, or those who have a greater burden of pre-existing health conditions, and included in those are obesity and metabolic syndrome. So clearly, we can identify those who are at the highest risk, and I would put our patients with obesity in that group, to try to target them for aggressive vaccination, timely vaccination, avoiding acute infection. And it's possible that there's a lower risk of COVID-19 in the event that they do experience a breakthrough infection.
Thank you very much to Dr. Ryan and Dr. Sherer, and thanks to you, our listeners, for joining us. As a reminder, to view the full program, Managing COVID-19 in Individuals with Metabolic Syndrome and Obesity, and to download a slide set showing key data from the various studies mentioned in this discussion, please click on the link in the show notes. As always, thanks for listening.